Thanks everybody for being here. I'm excited to be able to meet all of you. I don't often get to sit in on these DiSH sessions just because of clinic and things like that. But I love the idea of it, and I'm so excited to be able to be a part of it. So I was asked to talk on ketones, what they mean, why we care, what to do about them. And so we'll talk about this for a brief period, and then it sounds like plenty of time for discussion, questions. I have a couple cases if we have any, if we get stuck on anything. So what I wanted to cover today was to briefly go over the physiology of ketone production. I'm a big proponent of understanding what's happening before you, so you can understand where to intervene. I also want to explain the implications of ketones, particularly in patients with diabetes, since everybody can build up ketones in the right context, in the right situation. And lastly, for patients in diabetes, I also want to outline the management of ketones, some of which can happen at school, some of which should happen at home, and when we should think about escalating to a higher level of care, and lastly, to have that time to discuss. Okay, so starting off with what is a ketone. So within normal physiology, a ketone is formed as alternative fuel. Your body makes ketones when it doesn't believe that it has enough blood sugar around to run on. And so when you have low glucose situations, when you haven't been eating in a while, it is a necessary normal process to create ketones that allows your body to use glucose sparingly and only provide it where it's most needed. And it also allows you to minimize how much muscle you break down. So in normal situations, the ability to make ketones is a good thing. When you're in a fasting and low carb state, ketones actually come from fat. So you'll have fatty acid breakdown, and that will traditionally form acetoacetate. And so this is encouraged again by fasting or starvation states, and the hormone situations that are usually tied to that, low insulin. You'll also see more ketone breakdown if you have a high fat diet, more substrate for that. And ketones will promote insulin resistance, which makes sense. If you are in a starving state and your blood sugar is low to begin with, your body is going to want to minimize how much glucose is taken up and make sure that it's available to other tissues and cells. It is also a weak acid. So acetoacetate will get naturally converted to beta hydroxybutyrate and a proton, which adds to the acid substrate in your body. And in normal circumstances, those two are about equal in the body. In patients with diabetes, if the ketone production is getting out of control, you will see more beta hydroxybutyrate production, and that is naturally decarboxylated into acetone, which is what you smell when you smell ketones on someone's breath. So that's why paying attention to all of your senses, looking for that ketone breath in patients with diabetes is particularly important, because this ketone balance can become unbalanced in certain situations with them. And lastly, ketone, like we discussed, is a natural consequence. So it's a consequence of fasting. You'll also see it in situations of exercise and with dehydration. So if you're dehydrated, your body will break down fat content for its water content. So you're more prone to make ketones in those situations. And so in the normal body, normal ketone control, your insulin, if you're secreting insulin, your body is saying, I have enough glucose around for me to make insulin to control that glucose. And so having insulin will provide a natural stop to ketone production. Conversely, if you don't have enough blood glucose around, your body's probably making epinephrine, it's probably making glucagon, and those hormones will naturally prompt ketone production. It doesn't really make sense for your body to make both of these at the same time. So insulin and glucagon will inhibit each other. So if you have a lot of insulin, then it will stop glucagon from being produced and therefore stop ketones from being produced. And conversely, if you have a lot of glucagon around, then you're more likely to be producing ketones. So what does this all mean for patients with diabetes? This means that so what's particular in these patients is that they don't make endogenous insulin, and so they have less control over when they are controlling their ketone production and how well they're controlling their ketone production. Patients with diabetes also can have higher insulin resistance, particularly if they already have ketones around or they're recently out of DKA. And this means that that their exogenous insulin might be less effective if they have higher insulin resistance. If you have less of an insulin effect, then you have less inhibition of ketone production. And when you have a patient with diabetes, again, if they're going into DKA, their ketone production, ketone levels can become unbalanced with higher beta hydroxybutyrate. Higher beta hydroxybutyrate means that they have higher proton levels, and so they have more acid production. And so even though your blood has some natural buffering capability, if you're developing DKA or you're making a lot of ketones, that can overwhelm your body's buffering capacity, so your blood pH can decrease very rapidly. In patients with diabetes and in all patients, symptoms of ketones would include abdominal pain, nausea, vomiting, and if you are acidotic, your body is trying to get rid of that extra acid by essentially breathing it off, by producing more carbon dioxide. So patients who are acidotic can have heavy breathing, can have labored breathing, sometimes, but not always, they can feel like they're actually short of breath. Especially in younger patients who might not be able to verbalize pain or nausea, they can just have low appetite or irritability. They can just feel poorly. I also feel that I have run into particularly patients who are not taking their insulin very reliably or very consistently, and maybe have ketones a little bit more often, that those patients can be a little bit less reliable sometimes in terms of having symptoms. So I have also had patients who swear to me up and down that they feel fine, but if you know that they have missed insulin that day and you make them check their ketones, sometimes they will still have ketones. Or if they have a very high blood sugar, you'll check them and they will still have ketones. So also be aware that in patients with diabetes, if their blood sugars are high, that it's prudent to check for ketones whether they have symptoms or not. Who is at risk for ketones? This would include all patients with diabetes, including patients with type 2. It is harder for patients with type 2 to produce ketones because they do have often a little bit of endogenous insulin production, but they also have higher insulin resistance. So they can definitely still develop ketones. They can definitely still develop DKA. And so you want to pay particular attention to patients where you are suspecting insulin deficiency. So if you suspect that someone has diabetes and they have not been diagnosed yet, and so they're not on insulin, or if you suspect that they've missed an insulin dose, if they've been staying in a different social situation, maybe with a parent who's not as familiar with their care, or has a tendency to forget some doses. You also want to suspect it in patients who have insulin resistant states. So this would include obesity, like many of our patients with type 2 diabetes, existing ketones. So if they just got out of DKA, or patients with acute illness. Stress alone will increase your insulin resistance. And so patients who have the flu or have the stomach bug are at risk for ketones as well. You also want to have a lower threshold of suspicion, less likely, right, for school situations, right, but toddlers. So younger patients have lower hepatic glycogen stores, so they're more likely to be in a situation where their body feels like it's low on glucose and needs to make ketones. Pregnancy, as my attendings always constantly reminded me, pregnancy is an adolescent health problem, and it can happen in adolescence too. And so if you have an adolescent who's pregnant, they can be more insulin resistant and they can develop ketones more easily. Prolonged exercise, again, exercise is a trigger for ketone reduction. So if they have been going really hard, particularly if it's been really hot, really sunny outside, and they're dehydrated on top of that, then you want to suspect ketones there. And for a very limited number of patients, some of them will try to do or try to be on a ketogenic diet if they happen to have somebody has intractable seizures and they're trying to get better control of seizures. This is something that we'll run into in very rare situations. As far as what to do, thinking kind of the 10,000 feet big picture concepts, you want to do two things. You want to stop ketone production and you want to encourage ketone elimination, and those are not the same. So if you stop ketone production, the ketones that they have already made are still there, and you want to be working on getting those out of the system too. So to stop ketone production, essentially you want insulin. You just want more insulin in general. And we'll talk about how much insulin in a couple of slides, but if they have ketones, what they're getting right now for insulin is probably not enough. And so a lot of the time it means regular boluses, a lot of the time it means slightly above what they're used to getting. And a lot of the time it means having some modest intake of carbohydrates to allow for insulin boluses. Generally, I find that it takes less insulin to control their blood sugar than it does to entirely control their ketones, which means that a lot of patients will need to bump up their blood sugar at some point in the game to be able to continue getting insulin to control their ketones. To encourage ketone elimination, there's very little that you have control over, except for their hydration. So their body is already trying to exhale ketones, you have no control over that. Their body is already trying to oxidize some ketones, you have no control over that. But you can control how many ketones they eliminate through their urine. So as much hydration as you can reasonably encourage, if even in the midst of abdominal pain or nausea, anything and everything will help in that situation. If you see like modest intake of carbohydrates and encouraging hydration, a lot of the time what we're recommending to kids when they're ill is sipping on some sugar containing fluids, maybe every other sip being regular Gatorade or regular soda, not sugar-free for this situation, some juice, whatever they're willing to take. Not trying to drive their glucose is up to crazy levels, but a lot of the time aiming for like the low to mid 200s so they can get a reasonable correction even if they're not feeling like eating. And lastly, because we're talking about a school situation, whatever you do, whatever you're encouraging, just keeping some record of what you're doing, particularly because we want to pay attention to insulin half-lives, make sure that we're not stacking insulin if the patients do end up needing to go home. And so being able to pass on to the parents when they got their last dose of insulin so they know when they can next get insulin is really important. What not to do if somebody comes to the office or somebody comes to you for help with ketones. So if they already have ketones, then you want to minimize situations where they're going to produce more. So if they already have ketones, then I would discourage exercise. So discourage going out to recess, discourage participating in gym class, sitting out on those until the ketones are under control. Ketones alone do not automatically mean that they need to go home. I think that there's a lot of things to think about and balance here. So a lot of the time in a school situation, if it's just you plus, however many hundreds of kids, you might not have the bandwidth to take care of ketones, and they're going to get better and closer supervision at home. And so if you feel like that's the situation, then a lot of the time that's going to be the best thing for the patient. But also consider that there's going to be disruption of care created by waiting for the parent and travel time. Not all kids are necessarily going to get better supervision at home. So you do want to consider that and consider the patient's social situation. Also consider the disruption of quality of life created by repeated missed school, especially if their ketones are trace or small. A lot of those times those can be handled purely with hydration. And they might not necessarily need to miss an entire day of school for that. And as far as escalation of care, consider when you need to escalate care and when you don't need to escalate care. A lot of times ketones can be handled successfully outpatient as long as we're keeping in close contact with the parent and with a caregiver. Another thing to very, very carefully consider would be administering anti-nausea medications. We, of course, want patients to be able to hydrate well and to be able to eat so that they can continue getting insulin boluses. But also keep in mind that it would take away symptoms. And so it takes away a window into their clinical status. And so it's you could be creating a situation where you would miss worsening ketosis and miss an opportunity to intervene in a more, I guess, aggressive way if the patient is feeling less symptomatic purely because they got anti-nausea medications. So I have on rare occasions given the okay for anti-nausea medications for my patients, but it tends to be the exception rather than the rule, and it tends to be in very carefully controlled situations where we've discussed it really carefully with the family. Now, how much insulin we're giving to patients and when really depends on the situation, and it can be very, very variable, which I realize can be very highly frustrating on the patient care side and on the school side. The general rule is, if they're building ketones, they just need more insulin and they need more hydration. But there are different clinical practices. Be aware that if we're giving insulin, we're probably giving it every 2 to 3 hours because that's going to be the half-life of a rapid-acting insulin bolus. But everything on this list below, I have done in one situation or another, or I have seen people do in one situation or another. Here at UW, our standard practice is to give just a regular correction every 2 to 3 hours. But particularly if I trust the patient, if I know they're an adolescent with higher insulin resistance, if I'm in a situation where just trying to get things down quickly and I'm in a situation where I have to give you more insulin or we need to send you to the hospital, then I will give I'll give 10% above, 20% above, I'll give 10% at the total daily dose. I don't feel like you need, as caregivers in the school setting, to make a decision between these other options at all. But I do want you to recognize that, you can hear very different methods of practice from different practitioners, and to be flexible with that, and to realize that that's a suggestion that you might get once in a while if you call in. Okay. As far as what to monitor if you have a patient in the school with ketones and it's been decided that they can stay, so you do want to keep monitoring with ketones essentially every void, and potentially as often as every 2 to 3 hours to help you decide whether they need an extra insulin bolus. Keep in mind that urine is a filtrate of blood, and so urine ketones tend to run behind what is actually happening. So ketones will go down in the blood first, it'll get filtered into the kidneys, and then you'll see the ketones go down in the urine. And so therefore, something that's really important is keeping an eye on their clinical improvement. So a lot of the time you'll see decreasing nausea, better energy, they'll look a little bit brighter, they'll have less abdominal pain even before you see ketones go down. And that can be a good sign, something that you can feel good about, even if the ketones haven't gone down in the urine quite yet. And lastly, when things are going in the opposite direction, when do you worry and when do you call or escalate care? So really tricky situations that I think it would be particularly appropriate to have extra eyes and extra ears and extra brains to discuss and think about. If you have a kid with ketones and hypoglycemia, those can be particularly difficult to handle, especially if their appetite is low, if they have nausea. A lot of the time it's a game time decision. Do we send them in? Can they take sips? You know, how long do we watch? And so that just takes some discussion. Kind of the same situation, but a little bit more escalated, is intractable vomiting. That's going to limit how much they can eat or drink. So that we would definitely want to be discussing very carefully. And then lastly, where I think you really want to think very seriously about escalating care beyond sending them home, but actually just sending them to the hospital, is labored breathing, because usually labored breathing is a hallmark symptom of DKA, and quite honestly, more advanced DKA. So if you see that, that is usually like a send to the hospital situation. Okay, so that is what I have just for basics. So thanks for everybody's attention and care for our kids. I'd love to, love to discuss and take any